Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more. In today's podcast, we have the opportunity to welcome back our Mayo Clinic colleague, Dr. Ruti Sella, for a journal club on refractive cataract and refractive surgery. Welcome, Dr. Sella.
Thank you. It's a pleasure to be here. Thanks for having me.
We recently did a podcast with you that excited us. You shared about your practice in cataract and refractive decision-making and IOL measurements, choices, implantation. We're excited to have you back, and this is a journal club. And you've brought a couple articles for us to review, and we'll share with our listeners.
Yeah, so let's talk about the first article, which was published in 2025 in the Journal of Refractive Surgery. Specifically, this is on intraocular lens calculations with patients who have corneal ectasia. So let's just start with the basics. Why are intraocular lens calculations so difficult with, say, keratoconus and other corneal ectasias?
So these eyes behave differently, these corneas behave differently than other corneas. And there are a couple of explanations of why the calculations of the IOLs are so different in these eyes. First, patients with corneal ectasia also tend to have myopia, so their axial length is longer than average. They usually have a deeper anterior chamber depth. Both translate into a less predictable effective lens position, or ELP, that we mentioned in the previous podcast. So we definitely get less accurate results with them. And what we saw is that if we use the traditional formulas for those patients, we get about a 0 to 18% or so of the patients within a range of plus minus 0.5 from our intended refractive target. So they don't do very well with the formulas that we have. Now, another thing that happens in those patients is that the ratio between the anterior and posterior cornea changes. And so formulas that rely on measurement of the anterior cornea and then extrapolate that to get what the actual power of the posterior cornea is, this relationship is different in patients with ectasia. And we need to measure the posterior cornea in order to get more accurate results for the IOL calculations. So another thing that we have is just worse accuracy in measurements in general, because their cornea is conic. So measurement of the center doesn't really give us an idea of what the overall power of the cornea is. And the tear film is very differently distributed in this eye, so we don't get as credible measurements and results in those patients. Sometimes we need different measurements. We need to repeat measurements. We need definitely to have a pentacam or a device that measures both the anterior and posterior cornea to get the right measurements.
That was my curiosity, is knowing these eyes are complex, knowing they are pitfalls, given their unique characteristics. What advances? How has the practice advanced? What have you changed? And you already mentioned one, the pentacam in particular, and measuring their corneas differently. Any other things you'd recommend people do in the workup of these patients?
Absolutely. So there are a couple of very important things. One is to make sure the disease is no longer progressing, because keratoconus is a progressing disease. It's true that it usually does not progress at the age of, the average age of cataract surgery, but we have seen cases that it has been progressing even at 70s and beyond. And we do have pellucid marginal degeneration, which is another type of ectasia where we do see progression even in more elderly patients. And we have post-refractive surgery ectasia that can also progress. So we first need to make sure that this is an actual ectasia, that the measurements were done correctly and we know what the diagnosis is. Then we need to make sure that we do not have progression in this diagnosis, because if we see a progressive ectasia, we do recommend to cross-link those corneas before we go and do cataract surgery, because otherwise their corneas may change after the procedure and then we won't get any accuracy. So that's definitely, the first thing would be to make sure that we don't have progression, and that sometimes takes repeat measurements of the same cornea to make sure that we don't have any change. And I would recommend to repeat measurements within 2 months or so, especially when the suspicion is quite high that we have progression. So that would definitely be the first challenge in those patients. Then the second challenge would be to make sure that we optimize the ocular surface and that we have good quality of measurements. The third would be to talk to the patients and understand, are they contact lens wearer? If they are, have they removed their contact lenses sufficiently, enough time before we did the measurements, so we do not have a warpage effect of the contact lens. It can flatten the cornea. and give us aberrant results of the
How many
measurements.
days?
Yeah, exactly.
How many days? Yeah, that's a question. So, we do say that with a soft contact lens, 2-3 days are usually enough. To be on the safe side, we usually ask for 2 to 3 weeks. But 2 to 3 days are usually enough. And then with the rigid contacts, you can find different places where it's written a little differently, but the rule of thumb would be about a month for every decade of use, or 3 weeks and then a week for every decade of use. So
It's good to know.
And another option, if this is a patient who's had contact lenses for 40 years, it would be to just ask them to not wear their contact lenses and then repeat the measurements within 2 months and see that it's the same. And then we know that there is no effect of Warpage.
So you're doing all these things to maximize their outcomes. I'd say most patients with, say, keratoconus have a lifetime of challenging optics, potential limitations in their vision that they can't be addressed because of corneal scarring or irregularity. Just share with our listeners kind of how you consent for cataract surgery. We're going to talk about your study here in a minute, but just in setting patient expectations for cataract surgery in this population.
Yeah, how do you counsel them
How do
differently?
you counsel them?
Yeah.
So it's extremely important to understand what the relationship is between the patients and their contact lenses. Are those patients who enjoy wearing their contacts or are okay with wearing them and want to keep wearing them? Because the advantage of keep wearing contact lenses is that we don't only correct with a toric lens, for example, just a regular astigmatism, but special contact lenses, including scleral lenses and rigid contact lenses, can give the cornea a whole new shape. And that may be the best solution for the patient. But if a patient is unable or cannot tolerate the use of contact lenses, then we better find other solutions. And I can tell you that with the technologies we have now, and specifically with the wider use of toric lenses, these can sometimes be my happiest patients because they can get fantastic results.
So learning from you in the last podcast and even now, it's obvious that you can make mistakes with this patient population, right? Choosing traditional
Absolutely, yeah.
formulas potentially is a major mistake. And so you're studying this, and you have studied this, and this paper is with 36 patients who have corneal ectasia, and they all have regular astigmatism. And your question really was, which toric IOL calculation does the best job? Is the most accurate, and how should we move forward? Should we combine formulas into one? So kind of walk us through this study and kind of set us up on what you were actually comparing.
So when I used to work in a private practice, I used to work with optometrists, and we used to run about 5 different formulas for each patient with keratoconus who was a candidate for a toric lens. And so again, this question came from an actual clinical need. Do we actually need that? And my group published a different study that showed that in normal eyes, combining different keratometry measurements from different devices doesn't really add to the accuracy of our final results. So we can use a direct measurement or an extrapolated measurement of the prediction of the posterior cornea, and we'll get pretty much the same results. But what's interesting is, can those formulas that directly measure the posterior cornea, and can the combination of different measurements actually increase the accuracy in corneas when it really matters, when the cornea is behaving very differently? And so this is where the question came from. And so we tested 5 formulas in this paper. One of them is the cane keratoconus that has one option. And the second is the Barrett True K keratoconus formula, which is a formula that does not display on our IOLmaster 700. It's not something we'll get the output for, like with myopic LASIK and hyperopic LASIK, but to get all those options, we actually need to plug into the calculator that we can find in the American Society of Cataract Surgery or the Asia Pacific Cataract Refractive Surgery Association. And then when we open the calculator from there, we have different options. We have the predicted cornea, we have the posterior measurement of the cornea, and then we have the option to integrate different keratometry measurements as well. So the question here was, do they all perform the same and we're just wasting our time and resources, or do we really see improvement when we actually measure the cornea and when we use different devices? That was the question of this study.
So whenever you have IOL printouts of formulas choosing, there'll be multiple, and they're somewhat similar. Sometimes they're different. So in this population, with their corneas being so unique, and if you measure them on different devices and using different formulas, what was your sense? How varied are they as you look at them? And when they were varied, how did you choose?
So my sense was always that if we measure the posterior cornea, because it's abnormal, then it will add to the accuracy. That was my first gut feeling, but I didn't have that, so nobody really analyzed the results specifically with toric lenses, but we have a different study that was a meta-analysis actually of different formulas and which one is the best for keratoconus. Okay. So that's regardless of toric lenses. And this meta-analysis showed that the Barrett True K for keratoconus with a measured posterior cornea is the best formula, and the Kane keratoconus is best for severe keratoconus. So we differentiated between the severe cases and the mild to moderate keratoconus cases.
Not being someone that manages keratoconus, how did you discriminate between your average keratoconus and a severe?
That's the K measurement, so the steep K and how severe it is. So, cases that are, the K is higher than 50. 50,
okay.
Yeah.
And when you talk about the best, going back to that, how do we define success here? What are your primary metrics when you're doing these types of studies?
So when we look at monofocal non-toric lenses, then usually we look at the percentage of eyes that end up within a specific range of 0.25 diopters from refractive target, 0.5 diopters, 0.75 and 0.1 diopter from refractive target. And we also look at the absolute prediction error. So we look at how different our result is from what we intended to get. And then when we do toric analysis, because we have implanted toric lenses, then we have the Vectorial analysis of the toric lenses as well as a measure of success, which is what this study was all about.
Right.
Now, one of the unique things, you and I have connected offline about this, is when you measure reliability change in astigmatism, so often in the literature, people just want to know what's the magnitude of the astigmatism. Did it go from 2.5 to 0.75, and are we happy? But when the axis can change, the magnitude might stay the same and the axis might change, or the axis change may complement or make the magnitude differently because of the vectors involved. So talk about in your analysis, you used vector study to quantify change. Share why that's important and what you learned in that process.
So there are previous studies that looked at results with toric lenses in patients with keratoconus, but as you mentioned, they looked at the spherical equivalent. They did not look at the vectorial analysis. Now, we all know that if we take a patient from a 2.5 with the rule astigmatism and they end up 1 diopter against the rule astigmatism, it's not a great result necessarily, although we have minimized the astigmatism or decreased it to a point. So I think what's important in the analysis of those cases is also the direction. So it's a vector. So we have to look at vectorial analysis and look at the centroid. So look at it as a three-dimensional shape, because there is the z-axis as well. Yep. So this really makes it more accurate when we look at success to see how that is distributed. What's the trueness, what's the accuracy, what's the precision.
Yeah. We just published on the PDIG, the Pediatric Eye Disease Investigator Group cohort, with Mike Krupka being the lead of that. And it was humbling to learn how complex that is, but also how important it is. If you really want to understand the science behind toric change, you need to have some sort of analysis, and how important that it will be going forward, as your article highlights. So thank you for including that.
Of course, yeah, and I have to highlight that now if you use different tools that you have, actually part of the European Society of Cataract and Refractive Surgery, you also have tools for analysis of toric results that make your life much easier these days when you take upon yourself to do studies that look at vectorial analysis.
I know we have another study to talk about, but just for high-level overview, so obviously Pentacam is very important. We really should not rely on predicted posterior cornea astigmatism, correct? But secondly, the integrated keratometry is really important for these patients, and really taking multiple formulas, which your practice was doing and what we're doing here, that matters. For those who don't have that, potentially the Kane keratometry or the Kane keratoconus is a good alternate.
Yes.
So I'm a retina specialist. I'm trying to figure this out.
You're doing great. No, I'm very impressed.
But maybe for the listeners, what can they do to try to be the most accurate in their own practice?
So, by no means I want to say that there is a huge difference if you do this or do that. Those are it's fine tuning. So I think you can do, the first thing is to be aware that the normal formulas, the regular ones, are just not working well.
Sure.
So do not use a Barrett Universal 2 formula to try and predict the refractive results in a patient with advanced keratoconus. That would not work.
Makes sense.
And you'd end up with a very hyperopic result. So what you can do, though, is use the specific calculators. That would be a great start. And then anybody today who uses, for example, the IOL Master 700 does have a true measurement of the posterior cornea, even if they don't have a Pentacam. And they can use that. They just need to be aware and know exactly where to plug it in the calculator, which is what we're also teaching our residents to do. And just be aware that this is an option. And in those specific corneas, it's also really important.
Okay, makes sense.
You touched on a number of takeaways. Other takeaways from this, this article as you've processed the results and written it up and shared in publication. But what other takeaways do you want people to understand in this study?
So, we had very diseased corneas in this study, about 36 eyes, and we got pretty good results with toric lenses. So some really hesitate to use toric lenses in this group of patients. And although the overall residual astigmatism was about 0.6, which is maybe 3 times more than we'd expect with toric lenses in normal eyes, this is still a pretty fantastic result for patients who have a very high astigmatism. So I think just looking at it as a valid option for this group of patients is quite the change if we look at what was common to do 5 to 10 years ago.
And just from my own understanding, because I don't manage these patients, you shared that this group of patients had regular astigmatism. There's certainly a lot of patients with keratoconus that have irregular astigmatism, and you brought up earlier the use of contact lenses, a scleral lens to help give them in your practice, referred here to the Mayo Clinic, there's a complexity involved, but kind of in terms of what an average ophthalmologist or corneal specialist would see that is in this realm of care, what percentage of patients are eligible because they're regular versus really are irregular? I mean, is it the majority one? Is it 50-50?
The majority of patients with keratoconus probably would not have irregular astigmatism. Unlike patients with pellucid marginal degeneration, that maybe most of them will have some regular astigmatism as well. And then the question is, do they want to correct all of the astigmatism with a contact lens, or do they prefer to have a toric lens? Sometimes, interestingly, by the way, the inferior steepening of the cornea that's residual after the correction also gives them a little bit of ed, and they may end up sometimes not needing glasses, which is a miracle. So
that's
nice to see those results as well.
Yeah. All right. We have a second
study
to talk about.
Sure, yeah.
And that also was in 2025 in JAMA Ophthalmology, a different journal. So this was all about femtosecond laser. So talk about the study and what was the reason you decided to look at this specifically compared to toric lenses.
So I think this study is very interesting for a number of reasons. One, because it's a randomized control study and we don't have many of those in the field. And the second is because it is trying to find maybe another superiority or an area where femtosecond laser outperforms manual cataract surgery or gives us an advantage that we wouldn't otherwise have.
And this is specifically for arcuate keratotomy.
Correct. So this is the uniqueness here is that all surgeries were done with the femtosecond laser. Patients had regular astigmatism, and they were correct. It was 0.75 to 3 diopters. That was their definition. And they were allocated into one arm of receiving the femtosecond arcuate keratotomy, and another arm that just received normal toric lenses. And then they compared them.
And this was published for listeners in JAMA Ophthalmology here in 2025. And it was done in China with, I think, lead authors Dr. K. Yao and Dr. Yibu Yu. Sorry if I'm mispronouncing their names, but it just want to make sure listeners can tune in and look for this if they're interested in. So in that study, thoughts on that? I mean, so they're all getting femtosecond laser cataract surgery, and they're choosing to correct their astigmatic correction different ways. I think they enrolled 196 patients and then followed them for 3 months and looked at refractive outcomes. Thought about the study design and what they were trying to do in answering this question?
So they had 98 eyes in each arm, and they only included one eye for each patient. It was done very well, and they had a very good retention rate. One downside is that they did only follow those patients for 3 months, and usually when you track astigmatism results, especially with corneal incisions, that you do need a little longer follow-up because sometimes they regress, and that is one of the criticism about correcting astigmatism with corneal incisions, that they may regress with time. The correction may regress with time.
And that regression is well beyond 3 months for many patients? Is that?
It can be. It can be an ongoing regression of 6 months, a year, and even later on, there still may be corneal changes, yes.
Yeah.
And so interestingly, they chose to do a superiority study and look at the astigmatic keratotomy and is it superior to toric lenses? Well, we know that toric lenses are quite the gold standard for correction of regular astigmatism.
What is the prevalence of using femtosecond here in the U.S. in most cataract practices, specifically for this, astigmatism correction?
So I think the one important thing specifically in the US is that the FDA has not approved low toric lenses. So we do not have available what we have in Europe, that is a 1 diopter correction of low astigmatism. So probably the advantage of having a femtosecond laser here is that you can address lower astigmatism that you can do only with femtosecond laser or with limbo-relaxing incisions that we can also do when we do manual cataract surgery. So I think that I do not have the specific percentage for you. I don't want to, just throw a number here, but I think that it's declining. That, many places, and even we in Mayo, we had the laser, but we're no longer using it, the femtosecond laser. It didn't really prove to be better than the manual cataract surgery.
So currently in your practice, at what level or what can you pull this is, from a non-cataract perspective of adults, what level of toric correction can you go down to currently in your practice?
The lowest that we can is 1.5 diopters.
1.5, okay.
Yeah. That's the lowest correction in the IOL plane that we have.
Internationally, are they using femtosecond or torics to go below that?
Yes, and we actually published a study about that too, about low correction of astigmatism. It's a very recent publication.
Ranging from like 0.5 to 1.5 then?
It's mostly 0.75 to 1 diopter in the cornea that would require about a 1 diopter correction in the IOL plane. And that is available. It's available all over the world except for the US because it's not FDA approved.
Okay. So in this group, talk about the results. So as you already commented, they set up the study trying to look for superiority, and that may have been a design choice that they may have regretted, but share.
Right, could have been a non-inferiority study, and then, essentially they found that there is no difference. But while it wasn't their primary outcome measure, they did show that when you look at higher astigmatism of 1.5 diopters and above, and when you look at against the rule astigmatism, then you do get better results, better accuracy with the toric lenses in comparison to the astigmatic keratotomy.
So talk about the strengths of this study. So it was adequately numbered and powered?
Yeah, it was randomized controlled, and it was adequately powered, and it was blinded in terms of whoever assessed the results. It wasn't blinded. That was maybe a weakness of the study. It wasn't blinded in terms of the surgeon and the patient themselves.
Sure.
And they had they chose to correct at 0.75 to 3 diopters, which is probably the most prevalent astigmatism that we correct during cataract surgery.
Why would the angle of the astigmatism matter in the result? Do you think that's wound placement, separate from their toric correction? It's interesting that with the rule versus against the rule would make a difference in outcomes. Is there something else that would be going on there?
Yeah, what can go on is the posterior cornea and its effect, because it contributes against the rule to the overall correction, and this is something that when you do the calculations with the posterior cornea, for example, you can account for that, and the astigmatic keratotomy is on the anterior cornea only.
Yep. Okay.
And how did they measure visual acuity? Like, what was their outcome?
So they did not use the ETDRS. That was one point that that is a weakness.
Sure.
Yeah, they use Chinese letters there,
optotypes.
which is optotypes specifically for them. Yeah.
And then another nuance in all of this is cost. And we have, We have Femtosecond itself. If you have the laser sitting there, you might as well use it for more than one thing potentially. If you can hit address the lenticular component, but also the corneal component. But where is the cost of Femtosecond currently? And Torics are, its own independent cost decisions. But does that influence internationally where you have more options, or here a decision like this?
Yeah, I think that femtosecond laser in general is more expensive, and definitely more expensive than the set of lenses, regardless of their power. If you do the femtosecond and then you also correct the astigmatism, you do take off the price of the lens, but it would still be more expensive, and you would use it for cases that are just monofocal non-toric lenses as well. So I think overall one of the reasons that it was adopted first but now not very highly adopted is the price. Mm-hmm. It's the price, and it's also the fact that you need the right setting, to switch rooms and do one part in one room and then the other part of cataract surgery in the other room, which just changed the choice of many surgeons who revert back to manual cataract surgery.
Yeah. So for your practice, for a patient with 1.5 diopters of astigmatism or more, toric IOLs are being used. They're effective. It's more accurate. For those who have low astigmatism, are you doing limbal relaxing incisions? Is that something that we're still training residents? I remember doing it back in the day when I was a resident, but.
Yeah, so we have a nomogram, and we can definitely offer that to the patient. My reservations would be that I see those regress with time. Mm-hmm. And so it's important to also explain to the patient that it cannot really fully correct or correct in a very stable way their astigmatism, but it is an option. Another option is sometimes to look at the calculations and see if we can, sometimes even with a 1.5, it may be overcorrecting a little bit, mm-hmm. but if you overcorrect against the rule astigmatism, they end up with a little bit with the rule, and that with time and age, patients have against the ruling, so the astigmatism changes back to against the rule, so leaving them a little bit with the rule sometimes makes sense. Mm-hmm. And then you can still use, if it's borderline, you can still use a 1.5 diopter, which would, for the long run, would make them happier with a toric lens.
Makes sense. For the light adjustable lens, can you correct astigmatism?
Light adjustable lens can correct up to 2 diopters of astigmatism.
Yeah. It's good to know.
Mm-hmm.
Yeah. Well, thank you.
Yeah, learned a lot.
It's a delight to help us unpack these articles. Always a thrill to just appreciate what you're doing in this realm and advancing the science and our understanding for cataract patients.
Yeah. Thank you for having me today. That was fun.
Yeah, thanks for being here.
Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.